at the end of the study, sorry, at the end of the session, session, you are supposed to understand the physiological function of anterior and posterior pituitary hormone. Then you should be able to identify the clinical features of acromegaly. Then you should be able to discuss the role of surgery and radiation therapy for a patient with acromegaly. Then you should be able to select appropriate treatment strategies for a patient who is having this condition. Then this is the topics we are going to discuss for today. So on Wednesday, we are going to discuss about the hyperprolactinemia, still anterior pituitary or pituitary gland disorder. Okay, fine. So what do you know about pituitary gland? Can I hear feedback? What do you know about pituitary gland?
There is anterior and posterior.
So it has actually two regions, okay, anterior and posterior. Okay, good. Another
the posterior is responsible in releasing oxytocin and vasopressin.
Exactly. Yes. What about the anterior lobe?
Thyroid hormone, thyroid stimulating hormone, prolactin.
Okay, exactly. But those are some of the questions you might get even in the board exam. Like those of you are going to register in Kenya, sometimes even they will ask you like outline 5 anterior pituitary hormone. So those are some of the questions you will be asked mostly in the physiology part of the board exam, stage 1. So pituitary gland is also known as the master gland because it is responsible for regulation of the other endocrine glands and body system. So we can say pituitary gland is like a supreme code. It can actually like giving instruction, giving a lot of order to the lower, to the other glands, mainly for the endocrine system. So anatomically, it is located below the hypothalamus, and you can see it is actually like a pea-size roundish organ, which is actually very small. So the weight of the gland is like 0.4 to 1 gram in adults. So you can actually even imagine how this gland is actually very small, but it is actually a master gland because of its function. It is more of actually working as an administrator in the body system. So anatomically, it has two lobes, anterior lobes and posterior lobes. So the anterior lobes are actually producing so many stimulating hormone, but the posterior is mainly, as you said, it is producing oxytocin and vasopressin. So this is how a pituitary gland look like. So you can see hypothalamus is like the supreme court, maybe pituitary is the high court. So every instruction should be obtained from the hypothalamus when there is a chemical stimulus, maybe due to low level of, or when the level of the hormone is low, then the chemical signal will activate the hypothalamus. Then the hypothalamus will actually send signal to the pituitary. Then it will actually escalate. So we can say like hypothalamus is the dean, pituitary is the chair of the department. Then the gland will be maybe the faculty members. Yes, so then finally the individuals will be the students. So this is how regulation will be carried out in the body system. So pituitary is a very tiny gland. So when you look at the anterior pituitary hormone, some of them are peptides and the other are glycoprotein, like adrenocorticotropic hormone, prolactin hormone, and growth hormone. Then also luteinizing hormone, follicle and thyroid-stimulating hormones are some of the anterior pituitary hormone, but the posterior one is mostly produced from the hypothalamus, but they are stored in the posterior part of the pituitary. That is why they are known as neurohypophysis. Yes, those are actually neurohormone. Then this is the most common type of anterior and posterior pituitary hormone. So remember, when a patient is actually having some problem in the pituitary gland, you can actually even encounter a growth hormone deficiency, even low level of prolactin, even adrenal insufficiency, even some problem maybe hypogonadism, even thyroid deficiency. Those are common conditions that will be encountered if a patient is having this problem. So that is why, but generally speaking, a pituitary gland disorder is very rare unless someone has done maybe any radiation therapy of the head or maybe any surgery or else if someone is actually having adenoma in the pituitary gland, the probability of having this disorder is very minimal. Then let's see about the function of the posterior pituitary hormone. Remember, the posterior part of the pituitary gland is usually innervated by nervous system stimulation from the hypothalamus, resulting in the release of the specific hormone, oxytocin and vasopressin. Remember, oxytocin is very important, especially for like during lactation. It is actually like very important hormone, especially for like ejection of milk. And apart from that, even during delivery, oxytocin is actually a very important hormone. So like the secretion will reach peak during labor. It is important for contractility of the uterus so that the baby can be ejected from the birth canal. Yes, so that is the most important thing you need to think about. Then the other component is it actually promote labor. That one I have already said. But then even during labor, we'll discuss by the toward the end about like the different stages of labor. Even during labor, oxytocin is usually given intramuscularly for augmentation. So it can actually like there is endogenous oxytocin, but the more you apply, the more you give oxytocin exogenously, now the labor state will be promoted. Okay. Then that is very important thing to note. But vasopressin, as you know, it is antidiuretic hormone, but mainly involved in water regulation for water reabsorption. So it's really important to conserve water, to absorb water from the collecting ducts of the renal tubule. So those are the primary functions of posterior pituitary hormone. Then, as we have seen even in the previous endocrine disorders, we have seen the hormone feedback regulatory system. The hypothalamus is the one which synthesizes the releasing hormone, so that regulates the pituitary. Then there is stimulation and inhibitory effect of the pituitary hormone elicits a specific cascade of response in the peripheral gland. So, like depending on the type of regulation, like depending on the level of secretion, now the hypothalamus will actually stimulate or inhibit the release of pituitary hormone. So that is the role of negative feedback mechanism. So generally speaking, this gland secretes the hormone that exerts negative feedback on the other hormone or hypothalamus pituitary axis. So this one is ultimately important to maintain the body hemostasis. So as you can see, this one is the regulation and function of pituitary hormone. So as I have said before, pituitary hormone or hypothalamus, pituitary hormone is mainly producing a stimulating hormone, but releasing hormone usually comes from the hypothalamus. So there is, you can see the growth hormone releasing hormone, prolactin, tyrotropin releasing hormone, even the gonadotropin releasing hormone, then they activate all those anterior pituitary hormone. So you can see there is actually, there is prolactin hormone, there is even growth hormone, there is thyroid stimulating hormone, there is even ACTH, follicle stimulating hormone, and etc. For example, when you look at one of the anterior pituitary hormone is growth hormone. In the liver, it activates the production of insulin-like growth factor 1. So this one is very important for linear and organ growth. So remember, without actually having the growth hormone, like the probability of achieving linear growth and organ development is very, very unlikely. That is why when a patient is having deficiency of this hormone, the probability of having uh, dwarfism or stunt growth is very, very high. So when you look at the prolactin, prolactin, the target organ is mammary gland. It is very important for milk production during like the for lactating mother. Then when you look at the TSH from the anterior pituitary, it is very important for the production of the hormone. Then ultimately, it is important for metabolism and heat production. That is the end result of the end function of the hormone. Then when you look at the ACTH from the anterior pituitary, then in the adrenal gland, it produces cortisol. Cortisol is actually having so many physiological functions in the body system. That is the principal role of this endocrine hormone in the body system. Remember, even like ovulation, those things, even maturation of the secondary sexual characteristics of the female and the male is usually depend on even follicle stimulating hormone and luteinizing hormone. So they activate the ovary, then they are important for ovulation. So without this, even ovulation will not be happen. So that is why when someone is actually having any problem, the anterior pituitary, there is high probability of even infertility. Then it's C, even follicular stimulating hormone and luteinizing hormone in the testes, they are important for production of testosterone, ultimately for sperm production and etc. So you can actually imagine how anterior pituitary or pituitary is like a master gland because it controls all those activities. When you look at the posterior part, remember the posterior hormones are usually produced from the hypothalamus, but it is actually secreted and released in the posterior pituitary, vasopressin and oxytocin. Oxytocin is mainly for contraction and milk ejection. That is the primary function of oxytocin. Then vasopressin is mainly for water balance. It is important for water reabsorption. That is the principal role of the anterior pituitary hormones. So I'm going to pick like the most common anterior pituitary hormone disorder, like the infertility, hypogonadism. We are going to see it in the reproductive disorder section, but I just picked the excessive growth hormone deficiency or the most common type of anterior pituitary hormone or pituitary gland disorder. So growth hormone, the other name is known as somatotropin. Somatotropin. It is synthesized and secreted by the cell called somatotropes in the anterior pituitary. So it is the most abundant hormone produced by anterior pituitary hormone. So growth hormone is actually the most abundant, like the most abundant type of hormone that is produced by the anterior pituitary. And remember, it is very important to promote growth of all body organ. Even in the absence of gonadotropin, sexual maturation does not take place. So it actually promotes growth of all body organ, but there is a need of actually gonadotropin for sexual maturation. Then the growth hormone secreting somatotropins accounts like 50% of the hormone that is secreted by the anterior pituitary gland. That is why it is the most abundant. Then remember this growth hormone, as you have seen from this, it actually it actually stimulates in the liver and other tissues to secrete the insulin-like growth factor. Especially the insulin-like growth factor usually stimulates the proliferation of chondrocytes or cartilages and results in bone growth. So this is very important for linear and organ growth. But insulin growth factor 2 is mainly for fetal growth and development. That is the growth hormone, which is very important for that circumstance. This is under the regulation. Remember, the regulation of the growth hormone is mainly carried out from the hypothalamus. So that is another point to note. Then it actually stimulates growth hormone synthesis and secretion. But whereas the somatostatin will inhibit, as you have seen in the diagram, somatostatin can inhibit. Somatostatin normally inhibits the release of growth hormone, like dopamine and somatostatin. They actually inhibit, and there is excess amount of growth hormone in the body system. So that is how they are regulating in the body system. So in healthy individual, by the way, growth hormone is secreted in pulsatile manner. Like there is like several short bursts of occurring mostly during night time. But then most of the time, the growth hormone secretion is usually carried out during night time when like all metabolic activities or when all activities are actually significantly reduced. Like cholesterol synthesis, which is mainly carried out at night time. That is why when we are giving drugs for treatment of excessive production of growth hormone, mostly the best time to administer is at night time if the drug is given once daily. Then secretion of the growth hormone is usually lost during infancy. Then it actually increases during childhood. Then it reaches to peak during adolescence. Then it declines gradually during the middle years. Remember, when we are actually an infancy level, that is maybe our then when a person is actually in the baby stage or infancy stage, it is actually very low. It goes up during childhood and in adolescence, like at the age of like 20, it usually peaks during the adolescence stage. Yeah? Then after that, it declines gradually. That is why as we age, like the loss of mass, like loss of mass or loss of body mass is very, very common because of decline in the growth hormone. I don't know whether you actually came across like very tall person is actually even going to shrink at the age. This is actually because of growth hormone deficiency because of the aging. So this is how growth hormone production is carried out in the body system. Then what is the role of growth hormone? Let's see about the physiological role. It is very important in lipid metabolism so that it actually causes lipolysis, increase breakdown of fat. When you look at protein metabolism, mostly it increases muscle mass. It actually have an anabolic effect to the protein metabolism. That is why we are getting muscle during the adult age is because of the growth hormone. So when you look at the effect on carbohydrate metabolism, mostly it actually promotes glucose production. So decreased glucose utilization, increased insulin resistance, and the possibility of hyperglycemia is very high. So if a patient is actually having excessive growth hormone, the probability of having type 2 DM is very high because of anti-insulinic effect of growth hormone. So in short, growth hormone promotes production of glucose. That is the net effect of growth hormone on the glucose metabolism. So having said this much about the introductory sessions of a pituitary gland physiologic aspect, now let me take you through about the pituitary gland disorder we are going to discuss for today. Mostly, pituitary gland disorder is associated with abnormal level of the hormone in the body system. So I just picked like 4 of the most likely or like the most common type of pituitary gland disorder. So acromegaly, hyperprolactinemia, excessive level of prolactin, then hypopituitarism, and diabetes insipidus. So those are the most common conditions we might encounter. Uh, we might encounter maybe in the practice areas, despite or generally they are not very common type of endocrine disorders. Okay, maybe what does acromegaly stands for? Is there any volunteer who is willing to try? What does acromegaly stands for?
Can I try?
Yes, please.
It occurs due to excess growth hormone.
Okay. So have you encountered like any patient who is actually having a kind of like excessive, like maybe very, very tall person?
Yes.
Okay. So do you think it is related to growth hormone, like excessive growth hormone production in the body system?
I think maybe it's excess production by the pituitary gland, excess production of growth hormone.
Okay, yeah. Okay, good. Then that is mostly excessive production of growth hormone, but mainly this condition we call it acromegaly when it occurs normally in adult, like after closure of the epiphyseal cartilage closure. That one I will come. Then hyperprolactinemia is increased production of prolactin level. So what will happen by day when the level of prolactin is elevated?
I think it will mean because prolactin is produced by both men and women. I think for men will develop breasts or big breasts, big, extremely big. Yeah, yeah.
Okay. Okay, good. Then any other? Apart from that, are we expecting only like enlargement of breast or even there is a possibility of having discharge?
There is a possibility of discharge.
Yes. Remember the role of prolactin is actually involved even in milk production. Yeah, that is the role as you have seen from here. Have you seen here? It acts on mammary gland, and of course, it causes enlargement, and ultimately, even it is important for milk production. So, galactoria, we call it medically galactoria or frequent discharge of milk is actually very common. Then I will come to that point maybe on Wednesday because today we're going to focus on mainly about the acromegaly component or excessive growth hormone production. So pituitary gland disorder. So the tumor is located in the pituitary gland may result in excessive secretion of a hormone or may physically compress the gland so that it can suppress adequate hormone release. By the way, if there is a tumor in the gland, it can actually increase the production of the hormone or it can physically compress the gland so that there might not be adequate release of the hormone to the target organ, yeah, to the target organ, so that the target organ will produce the desired hormone. So the type, location, and size of the tumor often determines the patient's clinical presentation. I will come later. How does it actually look like? Then, if there is a damage and destruction of the gland, what will happen? The patient will have secondary hypothyroidism. I hope you know why it happens. The patient can have even hypogonadism. The patient can have even adrenal insufficiency because cortisol will not be produced. The patient can have growth hormone deficiency because growth hormone will not be produced. Then the patient can have even low level of prolactin so that they cannot actually even produce milk. Then if all the anterior hormones are actually diminished at once, we call it panhypopituitarism. You know pancytopenia? Pan stands for like decrease all levels of the hormone. Pan like decrease all. So when you say pancytopenia, if all blood cells are actually significantly reduced or significantly reduced below the normal range, we call it pancytopenia. So when you say panhypopituitarism, if all anterior pituitary hormones are actually reduced significantly, we call it panhypopituitarism. So there is a probability of having that condition if there is damage and destruction of the gland due to tumor or radiation therapy. So today, let's see about growth hormone overproduction. So growth hormone overproduction can lead to gigantism and acromegaly. So this condition is usually occur like before the closure of epiphyseal plates. So before the closure of those plates, like that is during the childhood, the patient will have actually excessive linear growth because that is the most common condition. Like before, by the closure of these plates, a child actually can have linear growth, and mostly up to the age of 22, between 22 and 25, that is the peak growth we are expecting, especially in terms of linear growth in child. But after that, mostly there is closure of epiphyseal. Then after that, the growth will be like horizontal growth. Like otherwise, there is very unlikely to have growth after that. So this condition is extremely rare and common in childhood. But acromegaly is a rare but very serious condition caused by too much of the growth hormone and mostly in adulthood. So this is mostly occur in adulthood. That means after closure of the epiphyseal plates. And mostly the patient will not have a linear growth, but this one you will see actually thickening or enlarging of the organs are the most common presentation in cases of acromegaly. So this is how you actually look like. So like this is a normal individual. So this is a normal individual. So have you seen the difference? So if you see this kind of people, this is really extremely long. So in 2000 and it is 2006. So when I was an undergraduate student in 2006, that is first year. So like I encountered one kid. He was actually like the tallest. He said he is actually the shortest in the family members, and he is actually like 2 meter height. 2 meter. That was the height of that person, and he was the shortest from the family members. So I feel like this kind of height is not really normal in some circumstances. Of course, height alone is not sufficient to be called. The patient is actually having this problem. Just let me pick urgent call, please. Okay, I'm back. So you can actually even see this height is not really normal. Huh? Mostly, apart from linear growth, the patient will have any other feature. That is why we are going to say the patient is actually having acromegaly. And of course, we are supposed to check the serum level of growth hormone. That is when we are going to conclude the patient is having this problem. So anyways, this is how acromegaly or gigantism look like. So epidemiologically, both conditions can affect equally, and it is very common. And like the onset of presentation is usually very insidious, so it will not actually like happen immediately, and it will take actually like cancer. Like cancer, it actually take long time to actually for the patient to present symptomatically. Okay, so this is how the epidemiology look like. Then, when you look at the etiology of this excessive production of growth hormone, is mostly caused by benign pituitary adenoma. So, like what we have seen in hyperparathyroid disorder, pituitary adenoma is the most likely causes of excessive growth hormone production. But malignant adenoma is very rare, like less than 1%. Like the most like malignant adenoma is responsible to cause like less than 1% of excessive growth hormone production. And most of the adenomas occur due to spontaneous genetic mutation acquired during lifetime, and no one really knows what causes this mutation. So that is why the most likely causes are not really known, but mostly it is due to adenoma in the gland. Then, of course, some type of tumor can actually produce ectopic growth hormone production. Like, for example, if someone is having an adenoma in the lung or maybe tumor in the lung, even in the pancreas, even in the adrenal gland, they can actually produce, they can actually secrete growth hormone, but mostly they actually produce growth hormone releasing hormone that can actually mimic or stimulate the hypothalamus so that it actually, sorry, that can stimulate the anterior pituitary to produce more of the growth hormone. So this is the ectopic production. The ectopic production, ectopic means something which is not originated, ectopic, PIC, which is not originated from the primary gland, but it actually activates the production of the hormone. So that is how it appears. A very common, a very common. So those kind of lung cancer or pancreatic CA or any tumor in the pancreas on those organs, the probability of causing exogenous or ectopic production of the growth hormone is very high. Then when you look at the pathophysiology of this condition in brief, this condition is very rare and it is very insidious disorder. So it occurs gradually over time. That is what I said before. And it's mostly caused by adenoma in the pituitary gland. And it actually ultimately overproduces the hormone. Yes. Then this type occurs after fusion of the epiphyseal or the growth plate of the long bone. Yes. This one I've already said, this one is very common in childhood, and this is because it happens before the closure of the growth plate, or the probability of having inner growth is very high in this condition. So having said this much, what are the clinical presentation when a patient is having excessive production of the growth hormone? Then headache and compromised visual function is very common. Why? If you look at this figure, the pituitary gland is almost closer to the optic nerve, which controls vision. So, if there is a tumor closer to the pituitary gland, it can actually physically contrast the optic nerve, and so that the patient will end up having any problem with vision. So the headache and compromised visual vision is very common when a patient is having this problem. Then, of course, the probability of having joint pain is very high. Abnormal neurological sensation is very high. This is a very common condition because the organ is actually excessively grown. So even sometimes it is beyond the capacity of the joint to handle these flows, and the patient will end up having joint pain. Then when you look at in terms of menstrual period, it can cause even amenorrhea because it can actually affect the normal production of follicle stimulating hormone and luteinizing hormone. And of course, it can actually disrupt even the gonadotropin secretion, and ultimately the patient will have impotence and decreased libido will be very common. But what is the most, what is very key is enlargement of the organs are very, very common. The nose is very large, and the lips are very large, and even the forehead is actually very large. We call it even frontal bossing, yeah? Like rickets. I don't know whether you heard about rickets. Frontal bossing is very common even in rickets. Then there is a probability of actually having excessive secretion of breast milk. We call it galactorrhea. But based on epidemiological studies, the probability of having acromegaly with excessive production of prolactin is very common. Like co-secretion of prolactin is actually very common. That is why galactorrhea comes in. Then in the organs, the problem with this one, there is abnormal enlargement of the organ. Organomegaly is very common in the liver, the spleen, and heart. This can ultimately even cause even the normal function of the organ will be impaired because of excessive enlargement. Then when you look at even, you'll see coarsening of the facial features, the hand volume is very large. Then fitting, getting the shoe and ring is not really very easy for those patient population unless they order from the factory, yeah, especially for shoe. So that is the major issues. And even there is increased spacing between teeth. Then the tongue can be even enlarged. So that is something which is very unique, especially when they're having acromegaly. Yes. So those are some of the clinical presentation. Apart from that, the growth hormone on the glucose level is usually promoting the glucose level it reduces utilization, but it promotes accumulation. So high blood sugar level is very, very common. Then because of the enlargement of many organs, the possibility of having cardiovascular problem is very, very high for this patient population. So finally, this patient can have even type 2 DM because of insulin resistance. So those are the most common findings you will encounter when a patient is having acromegaly or excessive growth hormone production. So how do we come up with the diagnosis? The diagnosis is based on diagnostic test, combination of diagnostic test and clinical features. That is very, very important. And mostly the growth hormone suppression test, we call it OGTT, but we call it oral glucose. I don't know whether you have covered in clinical chemistry oral glucose tolerance test. What does it mean? What does oral glucose tolerance test stands for? Anyone who can try?
Pardon the question, sir.
What does oral glucose tolerance test stands for? OGTT,
So
oral
I think
glucose tolerance test. Okay, huh?
you give glucose and then you measure the blood glucose levels after intervals to know like how if it's cleared from the blood. The
Okay,
glucose.
fine. Yes. So this is the most common test. We are going to discuss it by the way when we are discussing about BM. So you just give a glucose load, then you will see how the utilization of glucose in the serum, like 2 hours after loading glucose. But similar to that, even there is OGTT test for acromegaly. In normal circumstance, growth hormone is suppressed after administration of glucose. So in normal individual, if the growth hormone is actually normal, there is the growth hormone will be suppressed after administration of glucose. But if a patient is actually having acromegaly, uh, there is what? There is what? Despite you give them glucose, the growth hormone will not be suppressed. So there is postprandial hyperglycemia. In short, postprandial hyperglycemia can inhibit growth hormone for at least for an hour. But if the patient, if the growth hormone level is very high, like in case of acromegaly, if the growth hormone level does not decline to less than 1 nanogram per ml during the test, we can say the patient is diagnosed with acromegaly. So postprandial hyperglycemia normally inhibits for 1 hour at least, but despite we give and it is not actually is not reducing less than 1 nanogram per ml, we can say that the patient is actually having uh, uh, the patient is actually having acromegaly. So we call it oral glucose tolerance test. Then apart from that, this is one strategy we can do that. Then other strategy is looking the insulin-like growth factor 1 in the serum, and mostly it is elevated. Then apart from that, CT scan or MRI can be done to determine the size and the position of the adenoma. So those are the most common tests that can be used in combination with the clinical presentation to diagnose acromegaly. If so, how do we manage acromegaly? So based on your observation, acromegaly is excessive growth hormone production. How do we treat this excessive growth hormone production so that we rescue the patient from having so many complications, including even a loss of vision? Anyone who is willing to try? Geoffrey, can you try? Anyone who is willing? How do we treat acromegaly?
So maybe you have to reduce the levels of the growth hormones.
Sorry, you have to what?
Reduce the levels of the growth hormone.
Yes, how? That is the goal of therapy. How do we reduce the level of the growth hormone? What are the strategies? Huh?
You can give like dopamine, which inhibits.
Yes, dopamine agonists can be used because dopamine, if you have seen from the regulation, dopamine and somatostatin normally inhibit the growth hormone. So exogenous administration of somatostatin analogs and dopamine agonists can work. Yes. Okay, can you give me one example of dopamine agonist?
Dopa.
Sorry? Someone said something.
Levodopa?
Levodopa. Is this dopamine agonist?
I don't know.
Levodopa is just like is a supplement of dopamine. So it is not like a dopamine agonist, but it is just like a dopamine when someone is having Parkinsonism. But when you say dopamine agonist, those are actually a class of drug that can activate the dopamine receptor. So it's not really dopamine agonist. L-dopa is just a dopamine, synthetic form of dopamine.
How about bromocriptine?
Yeah, bromocriptine, exactly. Is there anyone who came across about bromocriptine? Anyone who came across with this drug? What is the primary indications of bromocriptine?
Parkinson's, I'm not sure.
Sorry?
I'm not sure,
You
but
just
I
tried.
think Parkinson's disease.
Yes, it can be used in treatment of Parkinson's disease. Yes. Any other indication?
Type 2 diabetes.
Sorry?
Type 2 diabetes, I'm not sure.
How does it help in type 2 DM? I think it has some role, but it is not really like it has some role in management of DM, but it is not really commonly used in the practice. So we do have like beta drugs that can actually control sugar level in type 2 DM. So how do you treat by the when someone is having like excessive milk production? For example, there is a scenario whereby a mothers can actually encounter like loss of their maybe neonates. So in that point, they will encounter like excessive production of milk.
Give bromocriptine.
Yeah, bromocriptine is the most commonly used drug that can be used actually to prevent like galactoria. So it can actually even prevent like milk production because of the effect on the prolactin level. I'll come that one by there. So bromocriptine is the most commonly used drug to actually like reduce milk production so that they will not actually suffer from because of the engorgement of the breast. Okay, good. So we
Question.
uh-huh.
What if the mother has already given birth but is unable to produce milk? What would you give in such a situation?
Yeah, but there is a drug by the I forgot the name, but I will get back to you shortly. That actually increases, but mostly the recommendation is like lactation, because the more you actually suckling, like the suckling reflex is usually activating the release of prolactin. So that effect will actually increases the release of prolactin from the anterior pituitary gland. Then ultimately it promotes milk production. So I was wondering, like from my experience so far, I never came across in the first few weeks they encounter after giving birth, they encounter that problem. But what the gynecologists usually recommend is usually let them suckle as much as try. Even I don't know about the name of the device, that device for like milking, yeah? That can even stimulate, but try to actually breastfeed as much as you can. Then maybe take adequate amount of fluid that can also stimulate milk production. Otherwise, I don't think so. Pharmacological approach can be commonly implemented, but there is a protocol that can actually increase the milk production if the patient is if the mother is actually suffering from that condition. Maybe I will get back to you shortly after the class in the group. Good question. Then the goal of therapy in this condition is normalize the biochemical disease marker, mostly the growth hormone and even IGF level. That is the goal of therapy. Then reduce the tumor size to relieve the tumor mass effect. That is the most common thing we need to do. Then preserve pituitary function, alleviate significant comorbidity, improve clinical sign and symptom. Those are the goal of treatment. So the treatment modalities for acromegaly, we do have option of surgery, we do have option of radiation therapy, we do have pharmacological modalities. But mostly, the surgical approach will be the most common treatment modalities that should be considered when a patient is having acromegaly, because the most likely cause of acromegaly is mostly adenoma in the pituitary gland. So there is a special type of surgery that can be considered to remove the adenoma in the pituitary gland. So if the patient is not responding for surgery and radiation therapy approach, then we can consider the pharmacological treatment modalities, somatostatin analogs, we do have dopamine agonists, and we do have even genetic engineering growth hormone receptor antagonist. So surgical treatment is the treatment of choice for most patients if they are having growth hormone producing pituitary adenoma. But of course, as a result of surgery, you will encounter few complications, including meningitis, maybe visual impairment. Those are actually some of the things you will encounter during the surgical after surgery. Even hypopituitarism can happen. So those are some of the complications, but of course, surgical resection will be the treatment of choice if they are having adenoma in the pituitary. Then radiation therapy is also another option. This one will be considered like an adjuvant therapy in a patient with residual growth hormone excess after surgery or after pharmacological therapy. So this one is used serve as an adjuvant therapy for excessive growth hormone production. Yes, if in case surgery and pharmacological therapy is not efficient to reduce the hormone level in the serum. Then this is another approach. So mostly, but the major problem with radiation therapy is, by the way, it will take long time to elicit it is full pharmacological effect. It may take like 10 to 20 years. Yeah, that is the major problem. So because of the delayed onset of action, pharmacological therapy is usually indicated as the bridge therapy in the majority of the patient. But apart from that, radiation therapy is actually having a lot of complication. Despite it has delayed onset of action, it can actually even cause permanent hypopituitarism. So the patient is supposed to be on lifelong hormonal replacement. That is a major problem. Then apart from that, the radiation therapy can actually cause damage of the nearby nerves such as optic nerves, so the patient will have even a problem in vision. That is another problem. So that is why, by the way, if someone is actually having a problem in vision, yeah, it could be like a primary infection, like at the primary site, it could be a damage in the brain, that is optic nerve. So don't rush to conclusion when you encounter a patient who is having a vision problem is a problem from the eye itself. It can be actually damage from the optic nerve. So that is the major limitations of radiation therapy, and mostly it is usually used like a bridge therapy, as an adjuvant therapy in case of non-response. The primary treatment is surgery if it's an adenoma, then if not, you have to use pharmacological therapy. So pharmacological therapy is usually done when surgery is not an option. When surgery is not an option, we have to use what? Pharmacological therapy. So this avoids the risk of having permanent hypopituitarism and other risks like meningitis and etc. What we have seen before. So what are the pharmacological modalities we're having in the market? We do have somatostatin analogs. Hopefully you have covered it somewhere when you are discussing about liver cirrhosis in the GIP component of clinical pharmacy. Then we do have growth hormone receptor antagonists, and we do have dopamine agonists. So those are the most common pharmacological treatment modalities we're having in the market. So as I mentioned before, somatostatin analogs, we do have the short-acting octreotide, and also we do have lanreotide is also another somatostatin analog, which is very important for treatment. So this one is the mainstay of pharmacotherapy for treatment of acromegaly when surgery and radiation therapies are contraindicated, or maybe when it has failed. So that is the strategies, and it usually mimics the endogenous somatostatin, and as a result, it inhibits the growth hormone productions. That is why we are going to give somatostatin the treatment of this condition. Ultimately, it can actually control growth hormone in IGF-1 level in 50 to 70% of the patients. Yeah, that is the effect of somatostatin. This one is the first generation, by the way, and it's very extremely short-acting. So the patient is supposed to take at least 3 times a day. And currently, we do have the newer generation somatostatin analog that can be given once daily. Anyways, that is how we are going to give. They do have some component of GI adverse effects, but mostly they are not as such bad. Then after you give octreotide, we are supposed to assess IGF-1 serum concentration level every 2 weeks after initiating therapy to further titrate the dose so that we can actually increase like 50 microgram per dose. But this is mostly the most common doses of octreotide, and usually we start like 50 microgram, then we titrate every 2 weeks with 50 if there is no response. Then the long-acting octreotides are the one which is currently used nowadays because of improved patient adherence and acceptability, because it reduces the pill burden. So in summary, this is the kind of octreotide preparation we're having in the market. So those are the newer agents, the newer agents that can be considered. So the short-acting somatostatin, the first generation one, is supposed to be given on the daily basis 3 times, but other one can be given every 2 weeks, every 4 weeks, and depends on the formulation. So this is how octreotide can be administered when a patient is having this problem. So generally speaking, somatostatin analogs, they are generally well tolerated, and they might have transient GI ADRs, but mostly they usually subsides within the first 3 months of therapy. That is the major issue with them. And diarrhea, abdominal pain, flatulence, constipation, nausea can actually happen, but mostly they subsides after 3 months of therapy. Then, when you look at a somatostatin analogous adverse effect, they actually inhibit the gallbladder contractility and decreases the bile secretion. Remember, bile is produced in the liver. Once it is produced in the liver, in the biliary duct, it's actually stored in the gallbladder. The excess amount will be actually injected to the duodenum for emulsification of fat acids. So, but the major problem with this class of drugs, it can reduce contractility, and ultimately it can increase the risk of gallstone. That is the major challenge we're having, but it usually occurs like after long treatment. Like if we use these drugs for more than 12 weeks, 12 months, the probability of having this problem will be very high. Then apart from that, another point to note with this class of drugs, they can suppress the pituitary release of thyroid stimulating hormone. Then ultimately, it can increase the risk of hypothyroidism. That is why when a patient is taking somatostatin analogs, it is good to monitor the thyroid function test. Is very, very important because of these adverse effects. So you can actually imagine at the clinical pharmacies where, at the pharmacies were actually in charge of monitoring any adverse effects of drugs, which is very, very, very key part, but it is mostly ignored by majority of the professionals. Then, secondly, growth hormone receptor antagonist. So the growth receptor antagonist, we do have only one so far. So far we do have only one growth hormone receptor antagonist. Agvisomant is the only genetically engineered preparation, and it is actually blocking the action of growth hormone. And mostly, this one is usually given in the refractory condition when a patient is not responding for surgery and radiation therapy, and it is usually given like 10 milligrams subcutaneously daily after loading dose of 40 milligrams. So the maximum dose is actually 40 milligrams, but you give them 40 milligram loading dose, then the maintenance dose will be 10 milligrams, then you titrate until the maximum dose of 40 milligrams. That is the most important. But the major problem with this class of drugs is the risk of liver toxicity is very, very high. So that is why we need to discontinue. If the liver function test like ALT and AST is 5 times above the upper limit, we are supposed to discontinue. Or if the transaminase level is actually at least 3 times upper limit, then maybe we need to continue. We need to consider to discontinue the medication. So in short, liver function test monitoring is very important. But I never came across this drugs myself, but I just am talking from the theoretical point of view. Then that is a major problem with this class of drugs. Of course, there is a possibility of having those other side effects, but what is most important is liver function test monitoring is very, very, very important. Monthly for 6 months, then after that we can do quarterly for the next 6 months, then biannually for the next 1 year, for the next year. So this is how the recommendation look like when a patient is taking this class of drugs. Then lastly, the other pharmacological therapy, pharmacological agents we are going to discuss is the dopamine agonists. Remember, dopamine is a neurotransmitter. Of course, you are going to discuss in detail about the neurotransmitter in the next semester from CNS or nervous system pharmacology, as well as the nervous system disorder. Dopamine is a neurotransmitter. It can actually increase growth hormone secretion in healthy individuals. But when you give them in a patient who is having acromegaly, it is actually having opposite effect. In normal individual, it increases growth secretion, but when in acromegaly patient, it actually exerts opposite effect and suppresses the growth hormone release from the tumor. So that is why dopamine agonists are commonly used in the management of this condition when a patient is refractory for frontline treatment, that is surgery. Appropriate for a patient with mildly elevated this IGF-1 level, and as well as if a patient is having prolactin co-secreting tumor. Remember, dopamine agonists are also actually suppressing the release of prolactin. That is why they're important in the management of even galactoria when a patient is encountering excessive discharge of breast milk. Okay, when I was working in Matave as an intern, I encountered one patient was actually complaining like excessive production of milk because of the use of risperidone. Do you know anyone this drug risperidone? Anyone who knows this drug? Which class of drug risperidone belongs to? Venetia.
Yes, sir.
You have not covered about the CNS part of the in medicinal chemistry.
We have. It's used for, I think, schizophrenia. I'm not sure.
Okay, but you know haloperidol, yes?
Yeah.
Or you know haloperidol is which class of drug?
Antipsychotic.
Speak up, please. There is no harm, by the way, to talk. Eh? Maybe let me go to another person. Noor?
So I'm saying I think it's used for schizophrenia.
Hello?
Yes, sir.
Hello?
Yes, sir.
Oh, can you hear? Eh?
Yeah.
Okay. Do you know haloperidol? Eh?
Yes.
Which class of drug haloperidol belongs to?
It's an antipsychotic.
Okay, how does it work?
I'm not sure, sir, but I know it blocks dopamine.
Exactly, it is actually very important dopamine 2 receptor blocker. Okay, so what will happen when you block dopamine receptor? I just actually want to tell you, like before I forget, that is why the risperidone come in, and this is actually like the practical, really like practical cases I have seen, even myself, when they're like a person who is not even a lactating mother is actually producing milk. Okay, what will happen when dopamine is actually blocked? Okay, Fevan?
I think there'll be increased dopamine, which will now inhibit the growth hormone. So yeah, I think it'll inhibit the growth hormone.
Remember, we are just blocking dopamine by the use of, he's just a psychiatric patient taking
So I think since you inhibit dopamine, when there is dopamine, there is decreased prolactin. So when you inhibit dopamine, there'll be increased prolactin.
Yes, then increased prolactin ultimately increases what? Milk production. Yeah, that is why when a patient is actually taking antipsychotic, you have to note the possibility of even galactoria. So especially haloperidol, like the second generation antipsychotic, from second generation antipsychotic, risperidone is the most notorious in causing prolactin elevation. In prolactin, of course, haloperidol can also do, but from second generation antipsychotic, risperidone is actually the most notorious to cause high prolactin level, and ultimately even what? It can actually what? It causes what? Excessive discharge of milk. Not only that, by the way, this class of drugs, by elevating the prolactin level, they can actually even cause decreased ovulation or infertility. Remember, when a patient is taking antipsychotic medication, because of the dopamine effect, they can actually increase the level of prolactin. Then prolactin can actually go through the hypothalamus and inhibit the gonadotropin releasing hormone. So FSH and LH will not be activated. So the progesterone and estrogen hormone, which is important for ovulation, will not be sufficiently produced. So there is a possibility of artificial menopause because of what? Because of antipsychotic. So when you are actually reading a certain drug substance, you have to actually look from the various perspective, which is very very important. So dopamine agonists are very important, especially when the patient is having excessive growth hormone plus co-secreting tumor that increase the level of prolactin. So dopamine agonists, bromocriptine is widely available in the local market. This is the most commonly available drug in the local market that can be used. So the initial dose is mostly 1.25 milligrams. That is the most common initial dose we are going to use for this patient, and it should be given at bedtime. So why it is given at bedtime? Why it is given at bedtime?
Because the growth hormone production is highest at night.
Exactly, yes. Growth hormone is actually production is very high at night time. So we just actually what? Mimic the growth hormone production. So the best time to administer is just like at night time. It is just like a statin. The statins, cholesterol production is very high at night time. So you advise the patient to take the statin at night time so that you can achieve maximum inhibition. So that is when we are going to use bromocriptine. Then we also have another dopamine agonist. We call it acromegaly is also another. This one I'm not very sure about the availability. So we can actually even use when a patient is having this condition. So there is not much difference by the among the dopamine agonists. Maybe there might be a slight difference in the potency. So this is the doses. Starting dose 1 milligram per week, maximum dose 4 milligram weekly. So this one is usually in the weekly basis, can be recommended. Then the most common side effects of by the dopamine agonists are nausea and vomiting. Why they can cause nausea and vomiting? Why they can cause nausea and vomiting? I hope Dr. Larry maybe take us about the pathogenesis of nausea and vomiting when he was discussing about the GIT disorders. Why dopamine agonists are responsible to cause nausea and vomiting? Because dopamine receptor is involved in the pathogenesis of nausea and vomiting. Remember dopamine receptor, serotonin receptor like the type 3, and also even histamine receptor, and they are mainly involved in the activating of vomiting center. So the more you are actually activating dopamine receptor, the probability of having nausea and vomiting is very high. That is why someone mentioned about L-DOPA treatment in Parkinson's disease is responsible to cause what? Nausea and vomiting. That is a major side effect of this class of drugs. Then acromegaly, it actually shows some kind of cardiac valvular abnormalities. So sometimes there is a need of monitoring is usually recommended when a patient is actually taking for a long period of time. So after that, you need to monitor growth hormone, IGF, and prolactin concentration after 4 to 6 weeks after each dose change. You need to monitor to see the effect. So in summary, this is the treatment algorithm of growth hormone producing adenoma. So when there is a pituitary adenoma, it can be a pituitary adenoma. Sorry. Can you see the screen? I think now you can see.
Yes.
So when a patient is actually, this is the summary, when a patient is having microadenoma and macroadenoma, the macro and macro is depending on the size, like less than 10 millimeter, and this one is above 10 millimeter. So this one mostly it cannot be even seen very well when you do CT scan. So if the patient is having adenoma, you actually do transsphenoidal microsurgery. Yeah, that is a surgical approach we can actually consider. Then surgery is like the front line. Then if the growth hormone is actually less than 1 nanogram, now you just monitor. No need of even giving additional treatment. If the growth hormone is above 1 nanogram, you actually give somatostatin analogs and you monitor. If it is still above 1, you actually give growth hormone receptor antagonist. Then still above, maybe you can consider radiation therapy. In case if the patient is not eligible to do surgery, what you can do is you start with somatostatin analog, then you monitor. Then growth hormone less than 1 nanogram, you continue the treatment, then you monitor. If it is above, you actually even give growth hormone receptor antagonist and you continue the treatment like this. So this is just like the summary of the treatment, the summary of the treatment of this condition. So maybe allow me to give you a summary of this video in the next few minutes. In the next like 5 minutes, it's just 5-minute video, so that it can summarize about this condition like before we end the session. Just allow me to show you the summary so that you can actually capture something. Okay. Let me share.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through acromegaly, and you can find written notes on this topic at ZeroToFinals.com/acromegaly or in the endocrinology section of the Zero to Finals medicine book. So let's jump straight in. Acromegaly is the clinical manifestation of excessive growth hormone, or GH. Now, growth hormone is produced by the anterior pituitary gland. The most common cause of unregulated growth hormone is a pituitary adenoma, so a hormone-secreting tumor of that pituitary gland. And this adenoma might be microscopic, so small that you can't see it on a scan, or it can be significantly sized so that it causes compression of the local structures. Rarely, acromegaly can also be secondary to a cancer, like a lung or a pancreatic cancer, that secretes either ectopic growth hormone releasing hormone, or GHRH, or ectopic growth hormone itself. There's a structure called the optic chiasm, and this sits just above the pituitary gland. And what this optic chiasm is the point where the optic nerves coming from the eyes cross over to different sides of the head and enter into the occipital lobe, which interprets those visual signals. And a pituitary tumor that has significant size will start to press on this structure called the optic chiasm. And pressure on the optic chiasm will lead to a stereotypical bitemporal hemianopia, visual field defect. So what this is basically a loss of vision of both of the outer halves of the eyes, because as the visual signals from the optic nerve come through the optic chiasm, the signals that sense the outer part of the visual field cross over in the middle, and it's this middle part that is pressed on by the tumor, and this causes loss of vision of the outer sides of the eyes, which we call bitemporal hemianopia. So how does acromegaly present? If there's a space-occupying lesion or a significant sized tumor, you might find somebody with headaches or this bitemporal hemianopia. It can also present with overgrowth of tissues secondary to the growth hormone. So patients typically present with a prominent forehead and a brow that we call frontal bossing. They can have a large nose, a large tongue, which we call macroglossia. They can have large hands and large feet, a protruding jaw, which we call prognathism, and they can develop arthritis from the imbalanced growth of tissues around the joints. Now, growth hormone can also cause organ dysfunction because it causes growth of tissues outside of the muscles and the skeleton. So it can cause a hypertrophic heart, or a very large heart that's not functioning properly. It can cause hypertension, type 2 diabetes, and it's also linked to colorectal cancer. How do you treat acromegaly? Well, you need to remove the source of that excessive growth hormone. So if you have a pituitary tumour, you can do an operation where you go transsphenoidally, or through the nose and the sphenoid bone at the front of the face, and surgically remove that pituitary tumour. And that's the definitive treatment for acromegaly in patients who have pituitary adenomas. Where acromegaly is caused by ectopic hormones from, say, a pancreatic or a lung cancer, then surgical removal of those cancers is also an effective treatment. If it's not possible to remove the cause of the excessive growth hormone, then there are medications that can be used to block the growth hormone. There's a medication called pegvisomant, and this is a growth hormone antagonist that's given subcutaneously and daily. More commonly, we use somatostatin analogues, which also block growth hormone. And remember that somatostatin is known as growth hormone inhibiting hormone. And an example of the somatostatin analogues is something called octreotide. And dopamine agonists also block growth hormone release. So this is things like bromocriptine that you might have heard of being used in Parkinson's disease. So just a bit of extra information. Somatostatin is normally secreted by the brain, gastrointestinal tract and pancreas in response to complex triggers. And one of the functions of that somatostatin is to block growth hormone release from the pituitary gland. Dopamine also has an inhibitory effect on growth hormone release, but it's not as potent as somatostatin. So that's why we use somatostatin analogues and dopamine agonists to help us block growth hormone release when you have a patient with acromegaly. So thanks for watching. I hope you found this video helpful. If you did, don't forget there's plenty of other resources on the Zero to Finals website.
Okay, this is all about today's session. Any question?